Good morning. We're both speaking to you without masks. That's because we are both in the privacy of our offices with the doors closed. So we're observing social distancing and other safety precautions during the COVID-19 pandemic.
Hi, my name is Jordan Christopher Ray. I'm a cardiologist at Mayo Clinic in Florida, and I specialize in cardio-oncology.
I'm Dr. Pooja Advani. I'm one of the medical oncologists in the Division of Hematology and Oncology, specializing in breast cancer. My research interest is cardio-oncology. So today, Chris and I are going to be both talking to you about this multidisciplinary emerging field of cardio-oncology. So I'd love to ask you, Chris, how would you describe what cardio-oncology is?
Oh, it's a great question. Thanks for having me. I have a particular passion in this area. Cardio-oncology is a new budding field that has been around mostly because we've been so successful with cancer treatment that we have to start focusing on all aspects of patient care, particularly cardiovascular care. And so the nut of cardio-oncology is protecting and monitoring patients' cardiovascular systems both before, during, and after cancer therapy, with the outcome of being as long of a survival as we can get from all sorts of aspects of disease, not just cancer. So that's where the majority of my specialty comes in, and that's been the largest focus over the last probably 5 years in this field. Pooja, I'd like to know from your perspective, what therapies are commonly used that can cause cardiac toxicities?
So Chris, adriamycin or doxorubicin is one of the most widely used chemotherapeutic regimens in breast cancer treatment. We use it in the preoperative setting, which is called the neoadjuvant setting, and in the postoperative setting or the adjuvant setting. This has historically been associated with a higher risk of developing heart failure, particularly at higher doses. Anti-HER2 therapies such as trastuzumab, commonly called Herceptin, is also used in a subtype of breast cancer called HER2-positive breast cancer. It's seen in approximately 20% of women with breast cancer. These therapies have significantly improved the course and survival of our women with both early and advanced breast cancer, but they can cause heart failure as well. However, fortunately, most patients have experienced a reversible change in their heart function without heart failure symptoms or late onset of heart failure. And now we have relatively newer medications such as immunotherapy that can also infrequently cause heart problems. So Chris, a lot of patients ask me about what is their risk of developing cardiac problems with the breast cancer treatment that I will be giving them. Can you tell us which patients, in your opinion, are most at risk for such heart problems?
Yeah, of course. I think it's important to create a perspective in a patient's mind that we take an approach of individualized medicine. And so we know that there are specific risk factors for patients, but it's more important to focus on the patient as a whole and kind of thinking about every aspect of their treatment. We have a lot of patients who have had previous treatments either for different cancers or subsorts, and it's important to understand that those therapies can impact how we manage and treat patients in this current setting. But we focus on the medications that you described previously, the anthracyclines like doxorubicin, particularly at high doses. And we want to kind of record as a patient goes through their cancer journey the amount and exposure to these types of agents, because we know there's a dose-dependent relationship. And so the more that you get exposed to, the more likely that you are to develop weakening of the heart muscle, which in a lot of cases can be permanent if not seen quickly. So the amount of chemotherapy, particularly with the anthracyclines, is important. In breast cancer, especially left breast cancer, radiation is a technique that is used frequently, both in the lymph nodes and breast tissue area, and different techniques and different types of radiation exposures can affect the heart and the heart field. So much like with anthracyclines, the amount of radiation that the heart muscle actually sees plays a big role. So there are thresholds for radiation where the heart muscle can be affected in that standpoint. And then thinking about the combination, this is really where cardio-oncology and breast oncology comes together, is this combination of therapies. So we recognize that there's one particular aspect of one therapy that's important, but knowing that if a patient gets both an anthracycline and a subsequent amount of radiation, and then potentially the addition of one of the therapies you mentioned earlier, the Herceptin or HER2 therapies, that combination and orientation of therapies can have a dramatic change in their long-term cardiovascular outcome. For example, if we give anthracyclines and Herceptin at the same time, we know we place patients at particular risk. And so we rely on the breast team to create and cultivate a regimen for the patient that lowers the risk while being successful in breast cancer. And then we have to think about the flip side of things, the things that I focus a lot more on, which is the patient risk factors for just run-of-the-mill cardiovascular disease. Age plays a particular role in both long-term outcomes in cancer as well as cardiovascular disease. The general cutoff that I place is about 60 years. Beyond 60 years, I really want to focus on watching and monitoring the heart. And then thinking about the traditional cardiovascular risk factors. And so those are diabetes, uncontrolled cholesterol, uncontrolled high blood pressure, a family history of cardiovascular disease, obesity, smoking history. If you have 2 or more of these risk factors going through breast cancer therapy, it's particularly important that we monitor those and adjust those risk factors and modify them as best as possible, because those patient groups are at higher risk for developing cardiovascular disease. And then patients who have had previous heart issues. So if you've had a history of weakened heart muscle before, if you've had a heart attack or a stroke before, it's particularly important that we modify anything that we can modify and create a scheduled monitoring program for those patients in the long run. So it's a complex question, complex answer, but I think the thing that we do really well at Mayo Clinic, particularly the relationship between the cardiology clinic and the breast clinic, is we focus on this individualized approach. We pay attention to the subtleties of how we're orienting the cancer therapies, and then we are paying attention to cardiovascular risk factors and not just being so focused on cancer, but thinking of a patient as a whole. Pooja, I'd like to know, when and what appropriate times do you think it would be to refer a patient to a clinic like mine for cardio-oncology?
So that's a good question, Chris. I mean, the goal of our breast cancer treatment is to optimize both outcomes from breast cancer and also to ensure that patient's cardiovascular well-being. We want to make sure that we strive to take care of the patient as a whole. We want to identify these patients early on in their course that will obviously benefit from referral to you or a cardio-oncology clinic. As you know, there are no set, well-defined guidelines when these patients should be referred and what exact patient population needs a cardio-oncologist referral. But like you alluded to earlier, often patients with pre-existing cardiovascular problems, as we identify them while doing their history and physical examination, these, like you have mentioned, are older age, history of tobacco use, alcohol use, high blood pressure, diabetes, high cholesterol, just to name a few, or a history of prior heart problems, someone who's known to have heart failure, someone who's known to have heart attacks. And we upfront know that these patients would be potentially getting chemotherapy that can affect their heart, such as Adriamycin or Herceptin, or one of the newer anti-HER2 medications. Those are the ideal patient population that I like to refer to you for early risk identification, prediction of how their course may potentially go, any relevant diagnostic or blood biomarkers that you may like to perform, and of course for close monitoring, and to call upon you if there is any issue during the course of treatment. So Chris, when I refer my patient to you in the clinic, what do you do with the patient? What do you offer the patient?
It's a great question. To me, I think one of my most important roles in medicine is patient education. So I very much want to cultivate an environment of empowerment for the patient, providing information for the patient. So I sit down and I really kind of give them that individualized approach where we talk about their cancer and cardiovascular journeys and how they kind of coincide with each other. So we discuss where they have come from both a cancer and cardiovascular aspect, what to expect through the cancer treatment journey, and then how we should monitor things long term. Because again, the focus, particularly with you guys in breast clinic, you guys have exceptionally good long-term outcomes. And so that's one of the things that I really stress with patients when I see is, you know, breast cancer is something that you guys do a very good job of treating. And I want to make sure that we give the best outcome for patients. And so I focus on, if we're going to think, you know, long term from breast cancer, we also need to have the same perspective from cardiovascular disease. So I sit down and I run through all of their traditional risk factors for cardiovascular disease. And I kind of treat them like a patient who does not have cancer. And we talk about all of the modifiable and non-modifiable risk factors. I love going through the patient scans. You guys order several different types of imaging techniques that, interestingly enough, can be cross-used in cardiology to look at different blood vessels, to look at the heart muscle itself, to look at the presence of cholesterol buildup in the arteries. And I provide a patient the visual representation of kind of where they sit in this world. And then we take these two pieces of information, we put them together, and then we discuss the next steps for the patient. What are we going to do from a monitoring standpoint? What are we going to do to focus on modification? And we outline a goal of care, and we create realistic expectations for patients. That's another aspect of my clinic that I really want to stress with patients. Is my job is to empower and educate, but then also not to create an environment where the patient feels overwhelmed or being told that they have to do things that they're probably not prepared to do. Because uniquely, there are actually some fairly simple things to think about when it comes to prevention from cardiovascular disease that I think patients kind of are misconceived about. So that's the biggest aspects of things. And then we talk about the therapies, what to expect from a cardiovascular standpoint, where the risks really sit. And it's a little bit interesting because this world is still new and growing, and we're learning more and more each day about which therapies are higher risk and which patients individually are at higher risk and how we manage and navigate that. So it's a lot of education, it's a lot of discussion, it's a lot of framing of perspective for the patient. And then long-term, it's support. It's making sure that all the things we talked about at the initial visit are maintained and monitored and looked after, again, with this huge long-term vision. Because the breast clinic is so good at treating their cancers now that we offer that type of perspective for patients. Pooja, what kind of advice would you give a breast cancer patient from a cardio-oncology perspective?
So, Chris, like you mentioned, I would also like to emphasize that breast cancer and heart disease have some shared risk factors. The age, alcohol use, obesity, a family history, physical inactivity, certain dietary habits. So our patients, by improving these risk factors, are not only investing in enhancing or improving their cardiovascular health, but they're also decreasing their risk of breast cancer and increasing their chances of having improved outcomes from breast cancer treatment. For example, a recent study showed that physical activity prior to the diagnosis of breast cancer was associated with a subsequent decrease in the risk of heart problems. So improving baseline cardiovascular health will also facilitate a higher rate of completion of cancer therapy. As you've mentioned, the survival outcome of women with breast cancer have significantly improved in the last few decades, with approximately 3 million breast cancer survivors now in the US. We really need to be proactive about optimizing the heart health of these women as well. So I'm really appreciative that you are here to partner with us in the breast clinic to achieve this outcome. So what are some of the simple measures that, women that are watching this video today can do at home to decrease their risk of heart problems without really having to see a cardiologist?
That's a great question. I think to tie into what you said previously about kind of advocating physical activity for patients. When I talk to patients about exercise, I think a lot of patients get really anxious, really nervous. There's a large number of patients that we see that don't have a structured exercise program. And the first perspective that the patient, I think, thinks is that I'm telling them to go do some CrossFit, go flipping tractor tires and hitting things with sledgehammers and jumping jacks and all this kind of stuff. And that perspective is important to create. That physical activity is important, but it doesn't have to be over the top and unachievable from that standpoint. So maintaining a level of physical activity is important. And it can be as simple as brisk walking carrying 2.5-pound weights while doing it. I tend to tell patients a good metric for knowing that you're getting some cardiovascular benefit from your exercise is if you're doing an activity that's aerobic, meaning it's repetitive and nonstop for about 15 minutes at least, it should be of an intensity where you couldn't whistle or sing, like you couldn't sustain holding your breath for a long period of time like that, but it's an intensity where you could still talk, you could have a conversation. And so patients could know that, well, if I can't talk with what I'm doing it too intense. If I can whistle or sing, then I'm probably not intense enough. And so that level is different for different patients. Some patients who have got a previous history of kind of an exercise program in the past will have to intensify their exercise routine. But for patients who haven't exercised a whole lot, honestly, brisk walking can get you to that level. And it's remarkable how impactful just creating a brisk walking routine every day and maintaining that kind of intensity of exercise can lead to long-term benefits. Like you referred to that previous study, that was kind of what they were looking at, is patients who have that type of exercise environment. Again, these aren't people that are going to some of these exercise programs and working at extremely high intensity levels. These are people that are doing structured, moderate intensity exercise programs that actually received that benefit. Secondly, I think it's important for patients to really understand and know their numbers. A lot of people, I think, are very shy about getting their cholesterol taken, or stopping in at the blood pressure station at one of the local grocery stores and kind of checking their blood pressure. But those simple metrics, just knowing where you stand in that window of risk, is important. Because a lot of those are actually modifiable. And so I think patients are very afraid to open that box and probably don't understand that most, if not all of those, are really modifiable risks, things that we can create both a lifestyle and, if needed, medication regimen for them to lower their overall risk from cardiovascular disease. And as you talked about previously, there are a lot of shared risk factors between both breast cancer and cardiovascular disease. And what's very interesting is when we focus on those central risk factors, we improve patients' outcomes for both breast cancer and cardiovascular disease. So if a patient comes to see me and we look at their scans, we say, oh yeah, you've got cholesterol buildup in your arteries, and we need to kind of do this, that, and the other to lower your cardiovascular risk. Each of those steps that we do, we actually improve their outcome from a breast cancer standpoint too. So it's a very nice symmetry, a nice unique aspect of patient care to be able to provide one perspective as a cardiologist and know that everything that I'm doing and every education point that I'm presenting to a patient is going to just as equally improve their breast cancer outcomes. And I think stressing that, it really empowers patients. They know that there's an added benefit to those kinds of things. So structured exercise program, knowing your numbers, blood pressure, cholesterol, knowing your family history are very important. And then taking steps to make sure that you're eating healthy. And so trying to avoid processed foods, trying to avoid red meats, and focusing on very large amounts of fish and vegetables, and not trying to make any of these changes just overnight. Because they're not sustainable that way. Making slow, planned ahead types of techniques where those habits and lifestyle changes become sustained rather than fads where you go a month of doing this really, really well and then you just kind of fall off the wagon again. I would much rather see patients be successful in 6 months rather than kind of just aggressively do things over a couple of weeks. And so I think that's what patients sometimes feel they're getting from their doctors. You need to make these changes tomorrow, and if you don't, you'll die. And I don't think that's necessarily the case. And I think being kind of persistent and focusing on the long-term goal is much more important for those patients. Pooja, this sounds like an emerging field that continues to gain importance. What research is being done in this world of cardiology and oncology, particularly in breast cancer?
So Chris, that's a really good question. And I think that we would like to continue this, synergistic relationship that we have between cardiology and oncology. We want to kind of take it from clinical practice all the way to research and bring it back to our patients. Want to focus on prevention, early detection, and optimal treatment of side effects to the heart from our cancer therapies. To this effect, we have analyzed existing data from patients that were enrolled in a large pivotal trial that Mayo Clinic actually participated in for anti-HER2 therapy. And we found that older women, those who had elevated blood pressure, prior use of another chemotherapy, mainly that Adriamycin chemotherapy that we've talked about earlier, and lower baseline heart function placed women at a higher risk for heart problems from anti-HER2 therapy, specifically trastuzumab or Herceptin. We then conducted a study in women actively receiving breast cancer, wherein we analyzed a sample of their blood for certain markers that were indicative of early heart injury and found some changes in these markers with their ongoing treatment, and this can potentially be used forward to monitor for signs of early heart problems in such women. We plan to validate these findings in a larger number of patients. I'm sure you have also engaged in similar research, and I would, later love to hear your opinion about this as well. But more recently, we've created a registry to collect important clinical information and blood samples from women willing to participate in this registry. These are primarily women undergoing breast cancer therapy. We ultimately want to create a model to help predict at the outset which women will be at a higher risk for developing heart problems. And so then we can send them over to you for more intensive monitoring. Also, some cardiac protective medications, allowing them to get the full benefit from the cancer therapy without really compromising their heart health. So Chris, I would love to hear from you what research you're doing and how you can continue to partner with us in this field.
Yeah, it's interesting because this has been a recent focus in the world of medicine. A lot of uncertainty is still out there and a lot of good research is being done. And there are new and interesting ways of monitoring patients. One of the great things about Mayo Clinic, especially this partnership between cardiovascular disease and breast cancer, is we get to offer patients some very advanced techniques in monitoring patients. We have advanced techniques in ultrasound of the heart. We have advanced techniques in CT and MRI. And all of these things are things that we are looking at and from a research standpoint, as well as implementing into our practice when we see our patients. We also have an ongoing clinical trial looking at patients with Herceptin, so those patients who have HER2 positive breast cancer. And we're looking at a specific medication and whether or not that medication being initiated before therapy starts or in the middle of therapy during certain aspects of their care that have changed, and whether or not this medication actually protects the heart from developing that weakening that we talked about. And so that's for patients who have HER2 positive breast cancer that haven't received therapies yet. We are prospectively providing patients cardiac protective medications, hoping that that is something that will impact patients in the long term. And then we're doing some exercise-based research as well, looking at some of the more aggressive but rarer forms of cardiovascular disease, particularly in the anthracyclines, where we're asking some questions about how exercise plays a role, as well as how different doses of those medications play a role in cardiovascular outcomes, and then seeing if we can use some more advanced MRI techniques to pick up on those patients who are starting to develop dysfunction earlier, to either provide medications or even alter their breast cancer therapy treatments to protect them from a long-term standpoint. So much like what you guys have mentioned before about focusing on prevention and risk assessment for patients is a high priority for us. So that's where we've been stressing most of our research aspects so far.
Well, this sounds very exciting, and I'm very happy to be partnering with you on this research. So Chris, can you summarize some of the important points we have discussed today?
Of course. I think for women who are newly diagnosed with breast cancer, I think it's very important to advocate for yourself, have very real conversations with your oncologist about the cardiovascular risk that they are expecting. It's also important for patients to know their numbers. So going into this time in their life, they really should know their blood pressure. They should know their cholesterol. Or they should feel empowered to ask for a consultation with a cardiologist to kind of help guide through. Part of cancer is this overwhelmment for patients. And we're here to kind of say, hey, this is my job. This is what I do. Let me help you, rather than just putting all of this weight on your shoulders. And then start those modifiable risk changes now, even before being diagnosed with cancer. Start your exercise routine, start focusing on diet health, focus on blood pressure and cholesterol management now, because those do impact not only cardiovascular disease, but breast cancer outcomes in the long run. So those are the things that I would focus on. Pooja, what kind of things or advice would you give to patients from your perspective from the breast clinic
I think pretty much similar to what you mentioned. We do get very busy in the breast clinic, trying to focus on the oncology care of our patients, but it is our job and duty to, take care of the patient as a whole and to be more proactive in discussing about, like you mentioned, the modifiable risk factors, to discuss about, any concerns that the patient has in regards to any of their previous history and how that may play into the current treatment that they will be getting. And we're always very happy to send the patients to see you. And if the cardio-oncologist is not available or a cardio-oncology clinic is not available, patients can always be sent to their cardiologist to have a more in-depth conversation about how to reduce their risk factors and what role they play in their current breast cancer therapy.
Very good. Well, I appreciate you spending some time with me today. I think this has been very educational and informative from my perspective.
Yes, likewise. And I hope that the audience finds the information we discussed useful, and we wish you good health.
You as well. Have a good morning.